I'm Dr. Anthony Maloof of Eyes and Faces and Corneal Oculoplastic Surgery, and this is a very long video of a keynote talk I gave at the Queensland State Branch of the College of Ophthalmologists in Australia in August 2025. This is the first of two talks, and this one is called The Basics, Cornea and Oculoplastic Surgery, The Basics. It's a long talk because it needs to go through a whole lot of things. But basically, it's about the molecular basis, the physiology, the psychology, and the philosophy of what we do. After all, we have to make a judgment for patients, and we can make that judgment based on our own biases, what we would like to do, what we think is going on, or by taking the effort to understand the molecular basis, the physiology, the psychology and the philosophy of that judgment, we can tailor-make treatments to the patients. Yes, everyone yawns and goes, oh my God, it's biochemistry, it's organic chemistry, it's fundamentals that we don't understand. We never even talk about it. Yet that's exactly what we depend on when we institute treatment. Hence, it's about 40 minutes long. It goes through quick, and yes, it will lose you. So the feedback I got was it was a whole lot of depth, and people don't want to go back to their undergraduate training. Yet that's exactly what we do, and that's my point. You need to understand it. So I do cover it. I'll cut it up later on and present it as snippets, but please enjoy.
Words. I feel honoured to be here. Just to broadly outline, so I'm going to talk to you about integrating two subspecialties. This is not a one topic thing, so I've got to do two subspecialties. And the only way I can really do that, don't take this the wrong way, I've got to strip your brain back down to medical school. So if any of you get sick or nauseous, I'm sure somebody can get you some more Danzatron, but please bear with me. This will continue into tomorrow as well. So strap in, I've got to go really fast. We're going straight down rabbit holes and we're going to do some quick turns. So let's see. I really believe that life is the pursuit of excellence, but you're going to stuff up. And so why? Why cornea and plastics? Well, our cornea cannot survive without eyelids. Fish have corneas, fish don't have eyelids. Last week this came in, this patient was sent in, older patient. There's metacel, ectropion, can I fix it? And I went, no, just ointment, that's all you do. She could see 6/9, I'm not touching you. So, proclaimers, yes, I've written all this myself, all the work is mine. There are 2 slides from ChatGPT that my staff got for me. And yes, try some of this at home. A lot of this will actually be relevant to you personally, to your health. And I'm going to move quick. Okay, I'll pick up the speed. Yes, my only financial claims here are that I owe the ATO money. And I haven't had not $1 from a drug company. I've been to some dinners and I'll never do it again. And I've never been to Epstein's Island, okay? So this is the dilemma, and it's really, really important. And I say this to the patients, it's the problem of invisibility in the area of the unknown. Patients don't care, nor do their referrers, if they can't see the problem or can't see the solution. They come to me, I've got to fix it, it's invisible, and they don't know what to do. It took me ages to work that out. It's a combination of evolution and psychology. And pretty much I tell all my patients, I'm operating on your mind first. So, I would sum it up as psychology, words, and wound healing. That's basically what it is. Manage the mind, manage the body, use the right words. And the surgery is the mind, and I tell patients this is psychosurgery. So psychology, we've really messed it up. Everyone's a narcissist, everyone knows everything, right? Anxiety, insecurity, everything has gone through the roof, and patients come in with all these psychosomatic symptoms. You see it all the time. I think talk should be about information, sharing information, trying to gain some knowledge, and if possible, understanding. They're the 3 levels. But most talks wear a scientific dress and they present data, and I bet none of you will retain percentages from today. You don't retain it from the last talk. You certainly won't use it. And when we sit there and go da 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 da, it is a bit of an autoeroticism. Evidence is not evident. So this is going to be observation-based. It's empirical, it's understanding. I'm not using data. I'm trying to stick with reality. Information before data, because machines use data, scientists produce data, humans and your patients rely on information, and you use that for problem solving. And learning is information gleaned through observation, not data. So, more patients die in hospital on the roads. Hospitals are more dangerous in the roads. That's what the data shows. REIF is data. Fire in context is information. Endothelial cell count is data, but the patient presents with information. Cataract surgery relies on data. That's why one of the reasons why you're so successful. My staff relies on information. Patients don't walk in with a number on their head. So, scientists produce data, clinicians rely on judgment, a brake engineer does not make the race team. So, there's a lot of sciencing, but not a lot of science, and we see that, and you've got to navigate it. We've been through scientific white noise, we're now sinking in scientific mud. So, that makes a lot of our science Scientology, which is religion. And so, as I say, you can be your own Tom Cruise, but go back to information. Don't take my word from it. John Onides, evidence-based medicine still remains an unmet goal. Interesting. It's always difficult. I felt it has been a disaster in the over 30 years that I have been involved in research. Very, very, very important, sobering words. Okay, so knowledge, it takes a lot of knowledge to know just how little you know, and the wrong knowledge is a guided missile with the wrong coordinates. Ignorance breeds arrogance. So, humility is recognizing what you don't know and what I call overcoming toxic doctorinity. So, that's how to dump the whatever and learn how to think about it. Corneal and oculoplastic is difficulty. My colleague said they want to know when to refer, what to refer, and I thought, let's give them a lens to look through. So, these are my 3 hours of my practice: restore, rejuvenate, reconstruct. They're actually all blended. I like doing a lot of things. There's a fish with eyes and a cornea and no eyelids, but I'll draw your attention to that. Yes, that is me. And when you're on a bike and you have a thought and you want to test it against nature, if you're lucky, it will punish you with pain. And if you're unlucky, it'll be your last thought. So I started off, I was going to be a cataract jockey. I was up here at Bundaberg. I was going to suck out every cataract and laser everything. And then I went overseas and we were doing decompressions, transplants, and a guy called Garrett Miller showed up in Moorfields, and I watched him do a Miller, and I thought, yeah, I want to do that. So I wanted to build a house. So I've got to thank people, Prof. Coronia, who's just a great brain to pick. It's Julian, as Graham mentioned, Brian Leatherbarrow, Linda, who was overseas when on call, very funny. My second brain, who's in the room with me, nature, risk, and uncertainty. And a little about me, I did none of this in my training. I consider myself to be a professional candle. So I'm going to talk about basics, and tomorrow holistic. So that's the conclusion. If you want to know what I'm going to talk about, that's it. A linear, deterministic, traumatic, immunological interference to the complex system of the body. That's what we do when we operate. In real words, it's a negotiation where a good outcome is your best result, and from there, you can sink rapidly. So, to understand that, let's talk about a couple of things. Words, concepts, and philosophy. A therapist is somebody who cures the sick. A cosmetic surgeon is also a therapist. Words are sounds that we use to communicate thoughts and thinkings. They can be used to misguide. That's what propaganda does. Build back better, for example. I tell my patients, I'm a linguistic Nazi when they walk in and say things to me. Healthy foods? Sure. Involutional, my registrar goes, involutional entropion. I said, what's involutional mean? She goes, age-related. No, it means to roll. But the problem is you stop thinking about the mechanism of the entropion and you think about the word. Microscopic surgery, I asked my trainees, why is it called microscopic surgery? And they point to the microscope. They transfer the technique to the tool and forget that every microscopic detail counts. Blepharoplasty. Patients come in and all dog, I want a blepharoplasty, and they pull the skin of it, and I just say to them, what's a blepharoplasty? And they stop. Because the wrong words, we're not going to have a meeting of minds. Hydrate the vitreous. I got taught this. My registrar said to me the other day, so I chucked it in. How do you hydrate something that's 99% water? Thought-terminating cliches. We use them all the time. I'm not going to ask anyone, but I'll be pretty willing to bet that no one here knows the difference between a lipid and a fat. I've asked everyone, but it's important. and that comes to oil gland problems, which all of you see every day. We use them interchangeably, they're not. A fat is a triglyceride, I'll bet you've forgotten what that is. But a lipid is a property, so it's water insoluble. All fats are lipids, but not all lipids are fats. Cyclosporin is lipid soluble. Pathology. I was taught through Robin's basis of disease to think about pathological basis of disease. I now think of pathology. It's my scope to look at normal, deviation from normal. Cornea means horny. It's a horny element. Conjunctiva, to join, to connect. Sclera, heart. If you remember, at the end I'll tell you the story of why we have white sclera and no other primate does. There's the article. Biologics, you hear them. What is a biologic? A biologic, penicillin is a biologic, insulin is a biologic, but what is the modern use of that? Something to alter a protein pathway or genetics. So you've got all your immunomodulatory, and they're amazing technology. Science, what is science? I ask every medical student that comes in, what is science? And their jaw drops, they can't tell me what it is. It needs to know, but it's actually an action. It's a tool, it's a verb. Now, in our social life, we all seek agreement. So picture yourself. This is addressed to males, but it's equally applicable to females, but don't get offended. You go to a party, all you guys, and there's this attractive woman there, and you're going, yeah, and she's talking to you, and you think, wow, she's into me. You're going to immense, yeah, we're in, you're talking about everything. It's agreement, and you think, we are a match. We agree. And then she says, I like drinking milk out of soiled nappies. And you're thinking, yeah, I do too, yeah, because you want to be agreeable. So we seek agreement in a social setting, and that holds us together. Narcissists and psychopaths love bomb you to seek your agreement. As scientific humans, we have to be the opposite, disagreeable. So you're wrong, you're not in anything, and it's like this guy, disagreeable. So imagine if your partner says, whatever you say is wrong, honey. You're always wrong. Are you in a disagreeable relationship, or are you an agreeable doctor? Perhaps, and then there's device-driven disagreement difficulty. How to be disagreeable. Every patient thinks they know everything, accepts no responsibility, and trades in the currency of offence. And that's the environment we have to work in today. So, candour, being open. Yes, your bum does look fat, won't get you far. Scientifically, why do you think your bum looks fat? Probably a better way to go about it. And that's exactly what I do. So, my registrars love it. I grill them so hard, but they always thank me at the end of the term. Always. And patients say to me, thanks for being honest, doctor. And it used to throw me. I'm not being honest, I'm being direct. So I thought about it, and here's where you have to consider it. If you're honest and direct, you're a pack leader. If you're dishonest and you're not direct, you're actually a psychopath, okay? And if you're not direct and you're honest, you get sued. So they're the things you have to deal with in the modern world. So agreement, I don't agree with most concepts. I think agreement is the fire of 1,000 suns, and nothing comes from consensus. And agreement is like a cupcake, sweet, pretty, but it's nutritionally depleted. And on my tombstone, I used to go, why not? And now I want, here is an unnice guy. So science. Science is observation. I'm going to speed up a bit, pick up the pace. It says what we do is wrong. It's disagreeable. It knows no protocol. Science proves nothing. You are not a scientist. You are a clinician. We like to pretend it. We're applied scientists. And I tell my patients, I'm a bio-psycho-socio-spiritual carpenter. That's what I'm doing. What Rajesh just showed you is precisely that. Science disproves. That's a null hypothesis. Most medical students have forgotten what that is. But it's simply this. Whatever you say is wrong, now disprove that. When did you last see negative results published? So, surgery is the tissue art of micromanagement, so it's bureaucratic in many ways. And this is another very important concept took me ages to understand. Complicated versus complex. Complicated is linear, predictable. Complex is nonlinear, unpredictable. The body is a complex system, a nested series of complexities which we don't have the intellect to understand. yet you operate on it all the time. And that patient comes in, a nested series of complexity in an environment that's a nested series of complexity, and you offer them a linear solution. So how do you deal with that? Occam's razor. For those of you who think it's the simplest explanation, that's not correct. It is the one constructed with the smallest set of elements and the least assumptions. Very important. The problem comes is when we take that concept and try and then throw it onto nature. That's called reductionism. That is beautiful complexity reduced to simplicity. Nature simplifies. We are complex. We've got to learn how to deal with it. So all our solutions are linear and they're predictable. Complex problems are not simple and there are no complex solutions. For example, breast implant is a linear solution. 2 steps, you go from one to that. There you go. Why? Because the surgeon feels good about it. That's why. So cataract surgery, you've got a linear problem. Linear solution, you've got objective outcome. It's brilliant. It's so successful because of those reasons. Come down to aesthetics, you've got a linear solution, you've got a complex problem, and you've got a subjective outcome. That's where all the problems lie. So it's a tailored art. We use scientific tools to navigate complexity. That's what we're doing with surgery. So here, what happens now is you guys have to do symptoms and sign, and you come up with the diagnosis. The diagnosis determines your treatment, but we're in an era where the treatment determines the disease and the diagnosis. So be very careful. Be very careful. For example, dry eye. Dryness is a symptom, dryness is a sign, dryness is a diagnosis, and dryness is a complex disorder. What are we dealing with? Linear remedies tend to determine what we do. So, management principle, risk and uncertainty. Most people don't know the difference. I'll run through it. Knowing what can go wrong and knowing what the chance, that's risk. Uncertainty, not knowing what can go wrong and not knowing what the chance is. Rajesh just showed you an amazing keratoglobus. What's the chance it can rupture? Then what's he going to do next? It's uncertainty. If you want uncertainty, ride a bike. And reasoning. We like to close loops. Sherman strip, dry eye, low, therefore you've got dry eye. Doesn't work. Strap on wings. Sounds like it'll fly, try it. Try it from the ground up, don't try it from the top down. So we can reason ourselves into a delusion, and that's what we often do in science. Take the word myth. Myth is our way of dealing with the world. And mythology is that expressed as a narrative. But I talk about medical mythology. Wet eye is the first step of dry eye. No, it's not. That's medical mythology. What's the most important communicating device in the world? The face. Then your body, then your movement. Any aesthetic patient will tell you that. Everything is aesthetic, every cataract's refractive. Now, why is that all important? Let's talk about eyelids. What is the eyelid? Is the eyelid structured? What is it? It's basically a mobile oil gland. That's what it is. It's also a demarcation between the sea and the desert, which is why the fish doesn't have eyelids. Eyelid function is really important. The upper lid and lower lid have completely different eyelid functions. The upper lid protects. Yes, it squeezes out and distributes fluid, more on that a bit later, but it also pushes against your eye. I haven't asked Rajesh about this, but I found the squeezers with DMEX will push their DMEC off their cornea. They squeeze so much. The lower lid is a pumping system. The middle of the face, where is it? I used to think it was here. It's not. Because the upper and lower lid are separate, it's at your lateral canthus. Everything below and everything above, I rarely mix the surgeries. They have different functions in different animals. The lower lid is the most treacherous. Okay, patient once asked me if they had lid surgery, will it change their facial recognition? I don't know, got no idea. So, I'll get through it, we're coming to the clinical, hang in there. 3 principles, you always know the sun will always rise. Guess what? There's a mythology. The sun doesn't rise, but we say it. You will die, and before then you will pay taxes. But here's how I would explain coronary plastics to you. It's very important. Number 1, lower eyelid always goes down. I call that the 4th rule. I tell all my trainees, doesn't matter where you put it, it'll go down, so put it bloody high. Everything on the face is aesthetic. Wound healing has the final say. Anyone that's done glaucoma, you know what I'm talking about. Patients cannot verbalise their externalised symptoms. I cannot tell you how many referrals for dry eye I receive that I end up doing a DCI. Patients will tell you what they're being told. Patients don't know and don't like to answer direct questions, and you must answer them. So I ask them a question, they don't answer it. I ask it again, they don't answer it. I just look at them and say, can I ask you the same question again? And then they answer it. Patients don't remember or refuse to. They don't care about the invisible. And medical legal issues are explanation and expectations. Happiness doesn't come from a scalpel blade. I write this to my patients before surgery, and nor does it feature in the post-op equation of surgery. And we have a lot of societal disorders coming through, if you haven't noticed. And if you're lucky, you get to age. Okay, the philosophical dilemma, 2 lower lid problems. You fix the first one, where do you set it to? The other side, or do you set it to normal? I call that the philosophical dilemma. I always set it to normal. The eye is not the window of the soul, the face is. Aesthetics is the value you place on a sense. So when patients says they're not happy, that's their value. This is really important. It took me a long time. I learnt this in anatomy, the different components of the orbicularis, but I actually use them all separately during surgery. And I will use different parts to do different things. It's really important. That's my algorithm for treating. Will it harm? Will it benefit? What's the uncertainty? And can we both manage the risk? The corporate rep has been, you will see, coming to theatre and they tell you what to do. I don't get that. I really don't like it. I don't get it. Next thing, you will hear technology, technology, technology. And I ask everyone, what's technology? Well, it comes from the root word techne, which means art, and ology, the science of, or to talk about. So basically, it's useful art. Tools, technique, technology. You'll see technology outside. Every surgical procedure is a technology. Medications are a technology. But technology shouldn't replace skill. That's the problem. So I talk about skill seeking. Upskilling technology, you've seen it with Rajesh already today. Great. Drugs, drips, cannulas, pacemakers, great technology. There's de-skilling technology. I'm not a fan of glue over grafts. Lose the skill and the tech owns you. And there's minimally useful. Yes, I've got cross-linking. Some of you will have knives. It's fine, I'll talk to you more about that tomorrow. But there's a whole lot of things. Here's one. I no longer use gold weights. This guy had a gold weight, facial nerve. I took out the weight, lifted the brow, lowered the upper lid, raised the lower lid. It is comfortable. Disease and disorders, really important. We talk about disease, but we forget disorders, and it's really, really important. Watch what happens. If you want to understand tissues, just watch what happens over time. Let's go to disease and disorder. A disorder can produce disease. Okay, very, very important. Hypertension is a disorder that leads to disease. Disorders lead to disease, and disease lead to disorder. Eye rubbing is a disorder. Stretch marks are a disorder. Diabetes is a disorder that can drive disease. When you do a full transplant, you induce disease. It's an environmental disorder. And I will make this statement, I think keratoconus is an environmental disorder, not a disease. Okay, to understand it, going back further, organic chemistry. Yes, you might feel nauseous. Here we go. How many molecules in a teaspoon of olive oil? Anyone know? Want to take a guess? Anyone? 1 trillion. I have no idea what that number is, but imagine you have put 1 molecule of poison. How do you detect it? Biochemistry is the application of organic chemistry, and it's what each one of you do every time you do something to your patient. So I've gone from meibomian gland disease through dysfunction back to disorder. Oil in the eyelid. It's really, really important. We've got oils in the eyelids. Oils should exist inside cells, not outside. If you doubt me, get some olive oil, inject it under your skin, see what happens. Exon Valdez is an oil leak. It's terrible. All outside the body, outside cells, induces inflammation, and meibom triggers all sorts of inflammatory disease. So it's multifactorial. You guys treat oil gland problems. I knew them as blepharitis. It's oil gland dysfunction. By the way, that's a true tarsal cyst. That's not a chalazion. Sebum on your skin, it's What is it? It's not oil. Meibum is similar but different. And I ask everyone, why is it called meibomian gland? Henry Meibum, 1666. It's named after a person. He described it. It produces meibum. Meibum is a complex lipid, not a fat. It's a lipid and it has esters. We'll come to that. Here they are. They're esters. I used to look at that and have a heart attack. Now I can actually understand it. So they've got heaps of things in alcoholic chains, esters, free fatty acids, the whole lot. And it differs from sebum. And when you look at it, it's at the base of dry eye. So when you see your patients coming with dry eye, that's at the base of it. I'll tell you straight out, everyone that comes in with dry eye for me, they're on drops twice an hour. I can get it down to BD or none. So when I try and call it blepharitis, it's a lot of things. Meibomian gland is wax. Every time you blink, you are waxing your eyes. That's fascinating. Okay? So what's really important here is that there is immune control of those oil glands and bacteria. The bacteria and the oil affects the immune system. The meibomian gland dysfunction or disorder has altered fats. The microbiota alters the fat. Why is that relevant? You go and say, take Chlorseek and use it for a month after cataract surgery, they come back with oil gland disease. Watch your people who've had recurrent retinal detachment surgery. They get oil gland disease on that side. Okay? Bacteria eat oils. There's this huge interaction. It's a huge area. They differ in meibomian gland disease. Meibomian gland disease, my management really consists of controlling the oils. Get rid of your vegetable oils. And I'll explain why in a minute. Manage your bugs and control the inflammation. And I can get most people off their drops using a simple remedy like that. By the way, we use the words wrongly. Microbiome, microbiota. I told you I'm a linguistic Nazi. What's the difference? Most people don't know. I'm not going to ask you. They're not the same. Microbiota is the organisms. The microbiome is the genetic material those organisms carry. And I'm sure that there's going to be a huge science evolving in that area. So there's heaps of variability, but things that happen to your external eye will change all of that. And you get all these knock-on effects. So, sorry about this. Fat, sugar, I've got to show you what they are, and collagen. That is a saturated carbon chain. Carbon is the molecule of life. That's a benzene ring. Toxic, it'll give you cancers. It has to be reduced in our gasoline because it's so toxic. Add a hydroxyl group and you get a phenol. That's toxic. Put them together and people pay money for turmeric on the upper right. That's a polyphenol. Unsaturated fats, look with the carbon-carbon double bond, flip it, cis-trans. This is one of the things I love. On the left is a carboxyl group. That thing is the key to life. Methyl group, carboxyl group, this is relevant, I'm coming to it. Unsaturated fat, a polyunsaturated fat. It's an acid, it's got that carboxyl group on it, it's a weak acid. When you guys give your patients omega-3, take your omega-3, what are you actually giving them? You're giving them an unsaturated fat that is a carbon-carbon double bond, 3 steps in from the methyl group. Omega-6 is 6 steps in, we can't synthesize 3 or 6. Omega-9 is olive oil, oleic acid. There's 6. Now, when you esterify them, such as that, vinegar and butanol, you esterify them, fats are an ester of a fatty acid to a glycerol backbone. Here you've got a saturated fat on the top and then unsaturated. Why is that important? By the way, a wax is just one carbon chain esterified. They're different chemistry. That is a saturated fat on top, but it's also got a polyunsaturated. Why is that important? Think of it this way. Flat pack furniture on the left. If you don't unpack it for 5 years, it's still pristine. Open it up, environment stuffs it up, it's damaged. And that is what happens to fats. So when you have unsaturated fats, they oxidize, they go rancid. All that omega-3 you have, most of it's rancid. You're doing your patients a disservice. Tell them to go eat chia seeds, walnuts, sardines. So I'm not a big fan of the supplements. The reason why we push them is because we can. If you've got too much omega-6, our answer is to increase your omega-3. How about you drop your omega-6? That's responsibility, change your environment. Cholesterol's not a fat. I think you can see that. It's a waxy sterol. We call it a lipid, but it's not a fat. Cyclosporin is not a fat, but it's a lipid. Why is that important? Think about it. Fats shouldn't be in tissues. Xanthoma is cholesterol in macrophages in tissues. Xanthelasma, yes, we cut them out. But if you cut it out, it comes back. Why? You've got leaking blood vessels. Now that I know that, I've got leaking, I remove a deep tissue, create a barrier, and fix it. It doesn't recur. Please stop telling your patients with xanthelasma to have their lipid profiles done. It makes sense, brain loop close, but it's false. There's xanthomas and xanthelasma. You get cholesterol crystals in xanthelasma. Where else do we get cholesterol crystals? Lipid keratopathy. And you get in gallstones. So lipid keratopathy is like gallstones of the cornea. And it happens through a process of nucleation, self-assembly and self-organization. Once those fats are in tissues, they mineralize. So, fish don't have eyelids, very, very important. There's nothing on the evolution of our meibomian glands or eyelids. But if you look here on the next slide, I want you to see this because this is when people will come in and complain of dry eye. Look at the lid margin. It's destroyed from chronic meibomian gland disorder leading to disease. That's what they're complaining of, not tear film deficiency. So it's like eyelid acne. I call it arthritis of the eyelid. It looks like that. And when you know what to look for, you'll see it. The meibomian glands go posteriorly, they open up, and these people complain of all sorts of problems. Now that can't be fixed surgically. The aim is not to get that bad. Meibomian gland can be exacerbated. There's microbiome, hormonal, but I've got to point out to you, watch the people that come in with chalazions repeatedly and inquire about their stress. Cortisol goes up. It's stress management. Diet is huge. There's so many crappy fats that gets incorporated into our meibomian glands. Stop it. And some people take steroids. You've got to ask them. Here's a conundrum. All my facial nerve paresis patients, I've never seen oil gland disease. Why? That to me says maybe muscle pumping is not the issue. It's everything else that triggers oil gland disease. And so when I manage it, it's very simple. Minimal Chlorsic. Please don't go to the chemist and get Chlorsic. You know, this compression, stop it. Just stop rubbing your eyes. In my practice, you rub your eyes, you get threatened with amputation. And the patients stop rubbing straight away. Manage their sleep. They sleep on the side, sleep like that. Do all that. Dietary change. Just clean your lid margin with your fingernail. Bit of steroid clean. Yes, I tell them to lose weight. But also, there are newer modalities. I was so skeptical of some of these modalities, I thought they were crap. But IPL and Tixel work. If you haven't heard of Tixel, it's great. And I'll come to that in a second. By the way, just quickly sidestepping, on the carbon rings, there's glucose, there's fructose, glucose and fructose, that's table sugar. Plants are made of polysaccharides, rings joined together. Trees are made of cellulose, that's why they live to 700 years and you die, because that is a strong structure. Proteins are important. There's the carboxyl group again, watch it. 21 amino acids make up all of life, isn't that fascinating? Bond them together and you get a peptide, and there are over 30, we call it a polypeptide. Why is that important? When we're dealing with thyroglobulin down here, that's a quaternary structure. Myoglobin is a tertiary structure. It's one massive complex structure. We can't really understand it. This is two proteins, quaternary. Collagen is much simpler than cellulose. That's why you age and die. And it's everywhere on what we operate on. Cornea, the sclera, the vitreous, the lids, it's all collagen. So, next thing about this is your skin prep. What do detergents do? When you prep the skin with betadine, I no longer use povidone iodine, I use chlorhexidine. So, a soap is that fatty acid that's mineralized. It binds to hydrogen, but you need heat. Your dishwasher needs heat and it needs to stir, otherwise the soap won't work. That's why you rinse your hands. But if you want to get rid of it, put sodium hydroxide on. That's called protein affinity. It'll rip things apart. That's why it's so dangerous to the eye. So the big thing here is benzalkonium chloride is a surfactant that was put there to dissolve tissues to allow the drug to get in. Now you know why it gives you stem cell damage. I deal with this all the time. Everything on the surface of the eye is inflammatory. I call eye surgery surgical immunology. Manage the inflammation, so we're down to steroids, inflammation, interferon, etc. The cornea is an antigenic sponge. It'll absorb antigens and lead to long-term inflammation. Transplant rejection factors in there. It's an antigenic sponge. The conjunctiva, if you haven't heard of Splendor Hopely, will absorb antigens and you get a chronic inflammatory response. Inflammation is a body of fire. We need it to heal. Nature's on our side. We get away with murder. And if you go in there 2 years later, you look and you think, it looks perfectly normal. I call that cellular intelligence. It's incredible. So there's lots. You've heard Tim Sullivan talk about IgG4. There's mucosal immunity. That's IgA. There's orbital immunity. And I think of it as mad egg, all different types of antibodies. Look at IgA. It's a pentamer. It sits on your mucosal immunity. That's what we're dealing with on the surface of the eye. IgG4 is its own subset of disease. Different names, all the one condition. Inflammation drives wound healing. In cataract surgery, you rarely see it. The ocular surface is an inflammatory powerhouse. It just is. And that comes down to toxic epidermal necrolysis, Stevens-Johnson syndrome, and how to manage it. Here's a person who's had mucous membrane pemphigoid after Stevens-Johnson syndrome. And the theory is antigen retention driving mucous membrane pemphigoid. There it is. This is important for your patients with inflammation. The thing I'm so strong about, vitamin D. We are so chronically vitamin D deficient. I don't take 1,000, I don't take 3,000, I don't take 10,000, I take 20,000 a day. It comes in preparation, it's really important, and you need to know about it, but we have variable absorption of vitamin D. Calcifediol is now on our registry, and it's really important for Stevens-Johnson's and mucous membrane. Somebody comes in with SJS, straight away I hit them with 600,000 IV of cholecalciferol, and if I can get my hands on that, they get that straight away. Here's something interesting. You use antifungals. It's an azole ring. Nature's incredible. That's imidazole, an antifungal. Look at histidine, an amino acid. Take off the carboxyl group, you've got histamine. Okay? And in allergies, so histidine and histamine. Histamine's an antifungal. Why is that important? When people come with periorbital eczema, what do? I give them an antifungal. And a lot of their periorbital allergic disease settles down. Histamine is an antifungal. If you patients have allergic eye disease, what do I tell them to do? Nasal rinse. Straight away, nasal rinse, antifungals, and then sometimes they have to go into Pexin, a great technology, works well. Bring it to an end. To be continued tomorrow. So pterygium is inflammatory. For those of you who do pterygium surgery, you've got to strap yourself in, they get lots of inflammation. What is pterygium? We were taught stem cell failure. Pterygium is an inflammatory response to intense light. Coronio described the coronio phenomenon. You've got constant light. It's a mobile scar. And if you're undertaking pterygium surgery, you are dealing with inflammation and wound healing. Please don't use mitomycin on the ocular surface for pterygia. Radiotherapy should be out. Pathology is in tenons. Laurie described it, do an extended tenonectomy. But what I would also advise you to do is make sure you do a graft. Don't have any tenons on your graft. Please suture them and you will control inflammation. But here's my 3 golden rules I give to my patients. They tell straight away, you're wearing sunglasses for a minimum of 6 weeks, wrap around, outdoor, all the time. And if you don't, I'm not going to see you again. They all wear it. They use their drops for a couple of months to get the inflammation under control, and they attend all their appointments. They're the 3 golden rules. So far, I haven't had a recurrence except for 2 people who didn't wear sunnies, didn't use their drops, and didn't show up and came back with terrible recurrence. Next thing, if you're going to do a recurrent pterygium and you're not confident with a primary, please don't do it. It's the rule of 2s because you're managing twice of everything. Twice the inflammation, the discomfort, the redness, the problems, everything. It takes twice as long. I'll leave it there for today. To be continued tomorrow.
Oh. Any quick questions? Thank you for giving this answer.
Sorry for all the organic chemistry and stuff, but it factors into everything you do.
It's just a lecture you really have to ponder on. But, that was a lot of work there, Tony. So,
Thanks, Ren.